CT imaging and proton therapy for prostate cancer. A PowerPoint presentation by Sean McReynolds. Hello, my name is Sean McReynolds, and I'll be speaking to you today about the use of CT imaging and proton therapy for prostate cancer. Causes for prostate cancer are unknown, and the symptoms include trouble urinating, weakened urine stream, hematuria, hematospermia, unintentional or unexplained weight loss, and erectile dysfunction. Men over the age of 50 and African American men over the age of 40 are at the highest risk, and risks do increase as they get older. Why the race affects risks of prostate cancer, we do not know. Obesity and family history of prostate cancer also increase the risks. Prostate cancer is diagnosed with a physical examination by palpate or from a prostate-specific antigen blood test. Some statistics are in 2021 in the US, there was 248,530 new prostate cases. I do not have any newer statistics on that one, but almost 60% of men over the age of 65 will be diagnosed with prostate cancer. It represents 13% of all newly diagnosed cancers in the US and 25% of new cancers found in men in the US. 1 out of 8 men in America will be diagnosed with prostate cancer, and it is the second most common cancer and fifth most common cause of death by cancer in the world. CT is used for simulation and planning for proton therapy, and we'll speak about that a little bit more very soon. The most common treatments for prostate cancer are surgical resection and radiation therapy. There's 3 different kinds of radiation therapy. The first one is contemporary photon-based radiation therapy. This uses high-energy X-ray photons from an external source. It does have a high-dose exit beam, unfortunately, which exposes tissues past the tumors to radiation. It destroys the cancer cells, but it can damage surrounding nerves, the bladder, the urethra, or the rectum, leading to undesirable symptoms of varying duration. The exit beam radiation, the external beam radiation therapy has advanced over the decades to make it safer to the surrounding tissues. Intensity modulated radiation therapy, or IMRT, is intended to reduce radiation in clinical complications, but it still delivers much more radiation to the surrounding tissues than compared to proton therapy. The contemporary photon-based radiation therapy has higher risks of gastrointestinal toxicity compared to proton beam therapy. The early symptoms can be a 4 to 17% chance of risks, and late symptoms lasting longer than 12 months are at 5 to 18% chance. The contemporary photon-based radiation therapy has slightly higher risks of genitourinary toxicity, but it is not substantially more, and the early risks are 0 to 45%, and the late risks are 2 to 32. The next kind of radiation therapy is brachytherapy. This permanently embeds radiation sources directly into the prostate in what's referred to as seeds, and it delivers radiation to the prostate over several months. They are left in there permanently, though. This use is in decline, and there's no discernible difference between the brachytherapy and the proton beam therapy in long-term disease control or 10-year survival rates. but that data was from older generations of proton beam therapy. I haven't found any newer ones, but like I said, it is in decline of use. Uh, the third type is proton therapy, and I view that as the best because it doesn't have an exit beam, and so it greatly limits um, uh, radiation to adjacent structures. But we'll talk more on that in the later slides. Before the patient can get proton therapy, they'll have to schedule an appointment in the CT department. In the CT department, the patient will get a pelvis scan without contrast, which will be used for simulation and planning by the doctor and the dosimetrist. The CT scan will gather images of the tumor and the normal tissues from many angles for the doctor and dosimetrist to study. Over here, we can see a cross-sectional CT scan. This is color enhanced to show the prostate. And on the cross sections here, on the patient's body, there will be three radiopaque black tattoos, just little dots that are about 1/16 of an inch. There'll be one on the right hip, one on the left hip, and one anteriorly on the abdomen. And those will be used as markers for positioning the patient for each proton therapy scan that they get, and it will be several. In addition to that, they will also have three gold targets inserted through the perineum, which is the area between the genitals and the anus, and that'll be inserted probably about here is where the proton beams will intersect. The proton beams themselves will be approximately aimed here and here, 30 degrees to each other. Pardon my crude drawing there. Also, while the patient is getting the CT, probably before so even, devices such as leg molds, headrests, sponges, and pillows will be custom fit to the patient's body, and they'll be brought with them to the proton therapy room for reproducing positioning to get everything as exact as possible. So now the patient is ready for their proton therapy. They're brought into the proton therapy suite, and this facility operates under the same licensure with the same regulatory agencies as X-ray facilities. The benefits of proton beam therapy is the precision pencil beam targeting that it uses, with size, shape, and depth down to millimeters with no exit beam to damage the structures behind it. Proton therapy targets the prostate with beams of protons that are generated by what's called a cyclotron, and this removes protons from hydrogen atoms and sends them through a particle accelerator to the desired speed for targeting. They are large particles with low energy transfer, or LET, also known as LET. The proton particles slow down as they penetrate the tissue, and they deposit a large portion of the protons at the end of their target range. This is how it has no beam that penetrates past the desired location. The central axis depth dose distribution is known as Bragg peak. The patient is positioned here. You can see the immobilizing devices from the CT department. And also here and here are X-ray detectors that they use for the positioning for those radiopaque tattoos that they had. Those are permanent. They'll always be there. So the detectors, X-ray detectors, are 90 degrees from each other. Will be used to line up the patient for the proton beam therapy. The treatments vary, about 5 treatments per week for 1 to 9 weeks, and they are about 2.5 gray per treatment. Proton therapy has been increased in use over the last 2 decades, is becoming more popular than the conventional radiation therapy. It has lower rates of early and late GU toxicity, but the actual rates were not mentioned in the study that I read. There's no evidence of significant difference in the rates of ED, erectile dysfunction, between that and the regular proton therapy. Rates of early and late GI toxicity are not substantially different, and there's no evidence sufficient to conclude that the proton beam therapy is superior to IMRT for cancer cell death. The main benefit is just doesn't have the exit beam, and so it's able to control like how much radiation is going to the patient. In one study, out of 1,860 matched pairs, 10-year survival rates were higher with proton beam therapy than contemporary X-ray based therapies. This was 80.1% versus 71.3%. Success rates are around 95% when detected early, but the chance of recurrence in 5 years are high, about 30 to 45%. So continued annual testing is important. Therapy results may take up to 3 months to get the results. The tissues need time to reduce in swelling and the tissue damage to heal before an accurate PSA test can be taken. And androgen deprivation therapy is often prescribed to help prevent further tumor growth. My thoughts for the process is when I first saw this machine and I saw the flat panel detectors here, and I saw that this whole arm structure moves, I thought it was actually a type of CT. I thought the CT was done here in the room, and I think that would actually be a benefit, an improved process, because the patient doesn't have to go to a different facility, and the CT appointment is about 2 hours long, and so that would free up the CT machine for more use for patients. Also, as prevalent as prostate cancer is, I think there should be more awareness programs in place, so people can be aware of it. In summary, prostate cancer can affect men over the age of 50 or African American men over the age of 40. Prostate cancer has several symptoms, including unusual bleeding, ED, or trouble urinating, and several risk factors, including age, race, obesity, and family history. It is diagnosed by a physician through palpation or a PSA blood test, and a pelvis CT without contrast is used for mapping and simulation, as well as placing targets and permanent tattooed skin markers that are radiopaque for position. Treatment options are surgery or radiation therapy, and proton therapy is the best radiation treatment option due to the precision beam without an exit beam that can do damage to adjacent structures. Though the rates of GI toxicity were similar to conventional radiation therapy, the GU or genital urinary toxicity rates were lower with proton therapy, as well as 10-year survival rates were lower as well. It can take up to 3 months to get results of proton therapy due to tissues need time for healing and the swelling to reduce in order to get an accurate PSA test. And finally, success rates of proton therapy are high, but also so are recurrence rates. So it is important to continue annual testing. Thank you for your time.